Everybody, my name is Mike Crowley. I'm the CEO at the National Kidney Foundation of Wisconsin, and I want to thank you all for being here this evening. I think you all got some food and drink. If you need to get up and get anything, feel free to do that. Housekeeping, walking outside, straight ahead, and on your left are the restrooms. Today's session on lupus and kidney disease is generously supported by Aurinia Pharmaceuticals. We have a representative here. We are grateful for their partnership and investment in community health education. Chad, over here in the purple shirt, has a table at the back with some excellent resources and swag. So please take a moment to visit with him after the talk if you haven't done so already. Also, I want to thank our hosts, Running Rebels, for sharing their beautiful facility with us. Natasha was very kind to help us coordinate this event here, and it's a great facility to have community health sessions. For 55 years, the National Kidney Foundation of Wisconsin has worked to improve the health and well-being of all people impacted by kidney disease and increase the availability of all organs for transplantation. We achieve this through programs such as early detection, advocacy, emotional support, and educational programs like this one, and for patients, professionals, and community members. We are joined also this evening by our friends and co-hosts at the Lupus Foundation of America Wisconsin chapter. Dawn, where's Dawn? There's Dawn in purple as well, so thank you. Their mission is to improve the lives of all people affected by lupus through programs of research, education, support, and advocacy. As the boots on the ground for Wisconsin's lupus warriors and their loved ones, LFA Wisconsin chapter is focused on reducing the time to diagnosis, ensuring direct services, and increasing access to treatment and care. Thank you, LFA Wisconsin chapter, for joining the National Kidney Foundation of Wisconsin in coordinating this event and your ongoing partnership. Before I introduce our speaker, I want to remind you that the information provided tonight is for general informational and educational purposes only, and is not a substitute for your physician's advice. Always talk with your physician before making any changes to your treatment plan. Dr. Zubin Lathara is a nephrologist and assistant professor at Froedtert in the Medical College of Wisconsin. He received his medical degree from University of Illinois College of Medicine in Chicago and brings 14 years of experience in practice. Please join me in welcoming Dr. Lathara.
Thank you, sir. Thank you for the NKF and thank you to Lupus Foundation. Okay, and this is really supposed to be, like you said, educational. Really your time to get an expert opinion in some aspects. Because Google is not your friend, I will tell you this. Google is not my friend as a doctor, so I can barely imagine for you or your loved one Googling things up. They call me Dr. Z because it's just easier than my last name, so if you can do that as well. The only thing I'm going to say is when you ask questions, if it's a very personal question, meaning this is what I'm on for treatment, what do you recommend? Ask me at the end of the talk. Because if I answer this question, I don't want to bias somebody else who's going through a different situation. That is the only reason I say that. And like he said, this is not, clinical decision making. I don't have all your data. But I can always try to help anxiety. I think anxiety is a big part of this. Can we go to the next slide? I have no disclosures. For the disclosure, I will tell you that my interest in this area is very specific. My mom had lupus, and that is the reason we came here. Because my dad said, if she has to die somewhere, let's get the best treatment possible at that time. So my interest in lupus is very personal, and my mom is still alive. She has lived with lupus since 1999, and living is, a nice term, but survival mortality is good, so it means she's living, but there's lots of ups and downs and mountains and valleys, and I'm sure in you or your family members, who have had lupus, you have gone through it as well. So we'll go through this. So my objectives for this talk is, first of all, we'll talk about the kidney a little bit, okay, what the kidney does. And then we'll talk about how do we measure kidney function. I'm going to say some terms like creatinine and EGFR, bear with me. Okay? It is just very simplified so you and I can have a conversation. And ultimately what we're doing here is what we do with our patients. Whether you like it or not, if you're in this room, you're a professional patient or a professional caregiver. Okay? It's just life, that aspect. But I want you to be able to have the information, so whoever is that white coat in the clinic, you can ask them good questions. Okay? And asking questions is not a bad thing. Okay? Especially if it comes to your loved one or you. So we'll talk about kidney function. We'll talk about protein in the urine briefly as well. And he has a nice pamphlet there about protein in the urine as well. We'll talk about lupus nephritis. So nephritis, neph is kidney, itis is inflammation. So really lupus in the kidney, not lupus by itself, but lupus in the kidney today. The stages of lupus I'll just briefly mention. I'll mention the kidney biopsy. Why am I doing all these things? Because all these things come into play for treatment. And then we'll briefly touch on treatment. Okay, so this is all just to get you a flavor. If you're a really professional patient, this may just be a review in some aspects. But if you're a caregiver, it will probably be helpful. Okay, and you can feel free to stop me. It's a small room, I'm happy to just listen to a question. Okay, am I speaking too fast?
No.
Please stop me. A little bit louder. Thank you. God bless you. Thank you for telling me this. Okay. Okay, excellent. Okay, the kidney. So the functions of the kidney, and God willing, most of you have two kidneys. Okay. I say most of you have two kidneys because some people don't know they have two kidneys till we do an ultrasound. There's only one kidney. But the benefit is you only need one kidney to work. Okay. When we transplant patients at Froedtert, we only give them one kidney most of the time. So most of you, God willing, have two kidneys, and this is a silly cartoon, but it works. What the kidney does is it cleans your blood, and it also maintains balance. So let's say you had this nice healthy meal here, and you decided to have like 5 beers. Well, you don't get 5 pounds all of a sudden. Your body gets rid of it because it's in balance. So the kidney essentially cleans your blood, keeps things in balance by getting rid of fluid, it controls your blood pressure. It controls, some of you guys, my wife, she likes to eat these hot pickles. Well, that's not good for your gut, but the kidney regulates the acid-base balance. Okay, so it does these things, and since I'm a kidney doctor, I love the kidney, so there is that. but the kidney, I think, it is a very understated organ, and it does work in background. Okay, so even if you have noticed, some of your family members, if they have lupus or you have lupus, and they have lupus in the kidney, your doctor tells you have 40% kidney function. You're like, what? I didn't know about this. Well, you're not supposed to know about it because the kidney keeps working. Okay, can we go to the next slide, please? If I said you had 40% brain function, you or your loved one is not going to be happy. They will know immediately. If I say you have 30% heart function, you'll be huffing and puffing. If I said you have 20% liver function, you'll be yellow from jaundice. But the kidney world, your kidney can work 30%, 40%, 20%, and you would not be the wiser. Now some people tell me, I feel the metallic taste. That tends to happen when your kidney function is really low, okay? Like less than 15%, okay? Regardless, the reason I'm mentioning this to you is not to scare you, but the reason I'm mentioning this to you is you need to do blood tests to measure your kidney function. That's the only way to do it. It's not based on how you feel. Now if some of you are like my mom is the most difficult patient. I love my mom. She says, you doctors just want to find more problems and make more money. And then I show her my paycheck, okay? So I'm a Medical College of Wisconsin faculty member. I get a salary whether I see 1 patient or 2 patients or 10 patients. So it's not this, but information is knowledge, and I want you to appreciate this. If you want to measure your kidney function, you have to do a blood test, whether you like it or not. That's the best way to do it. So the blood test that we do, it looks at the serum creatinine. Bear with me, okay? Creatinine. The creatinine is made in your body. It's removed by your kidney. So the kidney doesn't work well, the creatinine goes up. Does that make sense? Okay? So not everybody's creatinine makes the same amount. So this nice man here, he's more muscular, his body makes more creatinine than a very nice young lady, okay, who doesn't have as much muscle mass. So sometimes you will see a man's creatinine be like a creatinine of 1, and a lady's creatinine being a creatinine of 6.6, and both are called normal, even though they're different numbers. It just is based on what your body does. I think somebody tried to come in. So remember this, the serum creatinine in the blood test tells you an idea of your kidney function, okay? Your body makes creatinine, the kidney removes it, and if your kidney doesn't work well, the creatinine goes up. Have I lost anybody so far? And generally speaking, 1 for males is about normal, 0.7, 0.6 for females is about normal. Again, this is generally. If you're a lady who's 5'0", 98 pounds, your 0.4 is normal, okay? But I want you guys to appreciate this. Sometimes you'll see a lab report and it says L or H, high or low. Ignore that for the kidneys, okay? It doesn't mean anything to you. It's just gonna freak you out for no reason, okay? So the H and L for the creatinine does not matter because it is not standardized to you. Your doctor should explain that to you. Come on in. So the creatinine is how you measure kidney function, so bear with me. The eGFR, again, is a nice word, but the eGFR is giving you an idea of how much volume is getting filtered by the kidney. And that normally is 125 mils per minute. Don't think about remembering this number, okay, forget it. But I want you to think of the eGFR of an approximate percentage of your kidney function. This is being very simplistic, okay? Some of my kidney colleagues will argue with me about it, but that's okay. But it's been very simplistic to help you understand the concept of what your kidney function, okay? So the eGFR, you can use that number as an approximate function of your kidney function. So if it says 60, think 60%. If it says 70, 75, think 75%. If it says 40, think 40%. Okay? Have I lost you guys? So far, so good. Feel free to stop me. This is not supposed to bore you, but this is supposed to help you a little bit more. The urine protein to creatinine ratio is a urine test. It looks at how much protein you have in the urine. Protein in the urine has nothing to do with what you're eating. So don't stop eating protein because there's protein in the urine. It has to do with the filters of your kidney leaking protein because of some problem, whatever the problem is. In this situation, we're talking about lupus, but some problem, okay? So protein in the urine has nothing to do with you stopping eating protein. So just leave that alone. But we're going to do a urine test to check it. And normally, you can, and you probably have heard that if you see some frothing in the urine, that's protein in the urine, don't get obsessed about this, okay? Everybody's urine froths depending on how much water they drank, how hard it is. Then they all start getting worried and coming to me. It's okay, I'm happy for you to come to me. But it is not, I don't want you to be anxious waiting for this visit. So how do you know how much protein you have in the urine? You have your doctor check it, okay? And that will give you a slam dunk great idea of how much protein is there. You should not have more than 0.2 grams per gram. Forget the math. I'm just telling you that so you know. Let me do my slide, please. So this is essentially stages of chronic kidney disease, and this is the GFR. Remember I told you GFR, think of GFR as percentage. So most of the time, I will see stage 3 patients. So anybody that's in 60% kidney function, I will see in the kidney clinic. But if you're a lupus patient, we will see you even if your kidney function is slam dunk normal, okay? I'm not going to go to the definition of chronic kidney disease, but I want you to appreciate. So with the kidney, I just mentioned to you, the kidney controls, cleans your blood, keeps things in balance. If that doesn't work, what do? We do dialysis,
Yes.
okay? Dialysis is less than 8% kidney function normally. 8% is the GFR is what I'm referring to, okay? That's why I made you think of it that way. So 8%, less than 8%, then you usually need dialysis, okay? But what if you're like 20%, stage 4 is 20%, stage 3 is like between 30 and 60%. You can still be doing your regular stuff. You know, if I took an 80-year-old patient off the street, if I took 100 80-year-old patients off the street, most of their kidney function would fall in the stage 3 range, more than 80% of them, 80 of them. Why? Just because you lose some kidney function as you get older. There's nothing wrong with them. Their life is not affected, okay? So just so you understand, this kidney, you can that's why I say God smiles with the kidney, because you cannot have 30% brain function and be happy. But 30%, 40% kidney function is pretty good. But now if you're like my wife, she wants 80, 90% of everything, right? So I understand, okay, I understand, I get it. So, but you know, you are not talking about an illness that you did something to happen to. Okay? Many of you have genetic predispositions to it. There's almost nothing that you have done to get lupus, unless it's a drug-induced lupus. So, and I'm not trying to lower his expectations, but I do want you to understand the kidney world. I can have patients living at 30, 40% for a while. Okay, let's go to the next slide. This is what I mean. So this is a real patient of mine. You cannot see his name or anything. Okay, this is 2010. This is 2016. The red line is normal. So normal kidney function is if these dots are in the red line. So he's not normal, right? His kidney function here was 1 something. Here it's 1.3. Here it's, and I say 1 something, I'm talking about serum creatinine. So serum creatinine of 1 is, let's say, is normal. Serum creatinine of 2 means you have 50% kidney function. Okay, serum creatinine of 2 means 50% approximately, just go with it. 50% kidney function. Serum creatinine of 3 means he has approximately 28% kidney function. Okay, this is 2016. So if you just sat here and this was your kidney function and you looked at this, you're like, my God, I'll be on dialysis by 2017, correct? You're going straight up. So this is why you see a kidney doctor, okay? You see a kidney doctor because we don't want you to go on dialysis if we can help it, God willing, right? And we look at a trend. I have a colleague in the back, Dr. Ozie, who's also here now today. So you're 2 Medical College of Wisconsin faculty sitting with you. But the point is, these numbers, you have to find the cause of it and stabilize it. Can you go to the next slide, please? So this is the man. This is the same man. I showed you the slide up to here. This is 2017. This is 2022. And that's his kidney function slam coming down back again. It's not normal, but he's sitting for the last 6 years somewhere around the 40% range. So is he like, can he not do anything? Can he pee? Yes, he can absolutely pee. He can do his stuff. He's not stuck anywhere else. That's why I tell you the kidney world, God smiles in the kidney. You don't need to believe in God. I do believe in God. But God smiles in the kidney because the man can live a normal life with 40% kidney function. And the goal, if you really look at it, is the kidney doctor is try to stabilize the slope. Because at some point, if this line keeps going up like this, at some point over here, maybe in 2040, he's gonna be like 10% kidney function, right? So we have medications to help work for that, but that is what the kidney doctor is trying to do. Number 1 is to stop him from going to dialysis, which is less than 8% kidney function. But let's not wait till when you're 25% kidney function. You need to get it as early as possible. And to do that, you need to do blood tests, whether you like it or not. Okay, that's the only way to know what your true kidney function is. It is not going to be symptoms, because you can have no symptoms at 40%. You may have symptoms of lupus, but no symptoms of the kidneys. Have I lost you? You can ask questions. This is just your time. Can we go to the next slide, please? So that one of the examples I'm going to give you is this young person. I'm assuming he does not have any kidney problems. If I took her to a desert and gave her no water for 3 days, her kidney function from normal is going to go to like 45% because she's dehydrated with no water. Okay. So if I give her water back, the kidney function gets better because there was an insult and we fixed the insult. Okay. So sometimes when you go to see the doctor, you may be on some medications making your kidney function look like bad. But it's the doctor's job to figure out what that medication is, take it off, and see if your kidney function improves. The point I'm trying to make to you is often I see this in my clinic. Patient comes in to me for the first time because his kidney function is like 38%. I take off a medication, the kidney function is better. Patient thinks I'm a genius, but it really is, medication is side effect, we knew that. So the point I'm trying to tell you is don't get really upset by that one number. Can you go back to the previous slide, please? If you were this guy and you just sat here, you were like, my God, this guy's killing me. But then there is something around the corner if you can work with your doctors. And so it's very important. I'm glad the NKF, the Lupus Foundation, you need to have a support group. Seeing a doctor for 20 minutes is not gonna fix the anxiety that you have for weeks before you go to see the doctor. So if you're a patient, if you're a caregiver, you guys both need support groups. Because lupus is a chronic illness, as you know, and lupus is very challenging. And these kind of events, this year, I'm sure very anxiety provoking for this poor man. But, and you need to have a strong alliance with your doctors. When I say strong alliance, what does that mean? That means like, you should be able to ask your doctors questions and have them respond to it. Don't feel bad about it. I don't want to bother this person. No. It's your health, The more you talk and the more responsive they are, the better it is. That's a good working relationship. Otherwise, you're staying in anxiety, and what are you doing? You're on Google. You're on Google looking up stuff, and Google everybody's dead. Okay, everybody's dying. And I see this as a doctor because I looked up something for myself. It was bad. I can barely imagine my patient. So let's go on to the next slide, please. Next. Okay. So we talked about how you measure kidney function. We talked about serum creatinine. And you guys know the creatinine, think of creatinine of 1 as normal kidney function, to be very simplistic, and creatinine of 2 to 50% kidney function. Okay? Clinical manifestations of the patient with lupus nephritis, almost 100% of them, this is a study of many patients with lupus nephritis, almost 100% of them have protein in the urine. So often you will see the rheumatologist check your urine and say, there's some protein in the urine, you need to see the kidney doctor. By itself, it is not alarming. Okay? There is a medication to give fixed protein in the urine. We can give you that. But the rheumatologist is thinking of other things. Okay? You can often also have a blood pressure, high blood pressure. So if you have lupus in the kidney, you may not always have your kidney function go down. Your kidney function can still be normal. That's what this says. Only 60% of patients. Some very unfortunate patients have a rapid decline in kidney function, but the point I'm trying to make to you is, your kidney function could be normal, you could have protein in the urine, and you could have lupus in the kidney. Okay? So that is why I think you should have a good relationship with your rheumatologist and your kidney doctor at that point, if they recommend this. Blood in the urine is microscopic, so they may say you have blood in the urine, and that just elevates a suspicion for lupus in the kidney. Okay? Next slide, please. Okay, this slide is just some data. Data is good to know. Even if I said there's a 1% chance of something happening, if the 1% happened to you, it's 100%. Okay, but it's worthwhile knowing this because, like I told you, like I told my mom, I have no motivation in this. Okay? My motivation is just to help other people who were in anxiety like my parents were. Okay. So the incidence of lupus nephritis is not every patient with lupus gets lupus in the kidney. Approximately 38% is what they say. So 40 to 60% can have the blood in the urine, the kidney function going down. Your ethnicity does matter. Many of your African American patients have the highest risk. Okay, and again, this is nothing that you have done. It is where we are. Hispanics and Asians are the next. Caucasians are the last. I will say 10% of lupus in the kidney patients or lupus nephritis patients go on to end-stage renal disease, which is dialysis. So it's not everybody, it's 10%, so 10 in 100 people. That's a big number still, okay? And class 4 lupus, 44%. How do we know class 4? We'll come to that in 1 second. But 44% goes to dialysis over 15 years despite treatment, okay? Can you go to the next slide, please? But if you look at survival is fantastic. Okay, like in 2000, 2010, compared to the whole prior decade, survival in all lupus is up to 95 to 100%. But survival is a hard point, whether you're living or dying. And sometimes dying has much more clarity than living. Living is sometimes with patients with lupus, it can be very challenging. Be very challenging, especially when you don't know, is this lupus, is this nothing, etc., etc. So this, but it says, survival is pretty good, so that is a good thing, I would say. Can we go to the next slide, please? So these are the stages of lupus. Don't take a picture of this. I don't want you to memorize this or nothing. But there's 6 stages of lupus. Class 1 and class 2, we don't normally do immunosuppressive treatment. but these we do. So how do we figure out these stages? Okay, next slide. There is no blood test for the stages. We have to do a kidney biopsy. Okay, and I know some of my patients are very reticent about getting a kidney biopsy. So that's why I wanted to talk about it. As you can see, this lady is wide awake, so you're not falling asleep. And her head is looking at the monitor while she's looking at the needle go to her kidney. She doesn't see the needle, okay? And I do this a lot. I've done this a lot. The whole procedure takes about 15 minutes, 5-0. But the actual needle going in, we do it twice or thrice, takes half a second. So the actual injection, the actual biopsy is like literally done in 1.5 seconds, okay? But everything else is to take care of you and make sure we don't cause a nice big hematoma. Your kidney sees about 25% of what your heart pumps. So guess what? You put a needle in something that sees that much blood, you'll have some leakage of blood. But we try to make sure this is done very safely, and we're fairly good at it, I would say, at the medical college. You would stay overnight. But I would say, how much pain is there, doc? Because that's what I want to know. So the biggest pain is when they make the neck to go put the needle through. And if you guys want to know where your kidney is, feel the bottom of your rib in the back, and that is where the kidney is under it. So you cannot punch my kidney because my ribs are there. But that distance to go there can be, depending on what you weigh, can be up to 10 centimeters deep or 13 centimeters deep. So the nephrologist doing it has to numb you up. So they give you lidocaine. So if you had to do a kidney biopsy, you can tell your doctor, if you're going to do the kidney biopsy, I want a generous amount of lidocaine. There's no harm in telling them that. If you tell them, I'm very generous about it because, if I did it to my mom, what would she like? And my mom is very sensitive. My mom is very short and very sensitive. God bless her. But I would say, you should ask. There's no harm in not asking, number one. And number two, you should ask, how many of these have you done? Okay, these are all questions you should ask. It is within your right. Don't feel like the doctor's gonna be offended, my God, but this is your body. But it is a fairly safe procedure. You have to stay in the hospital overnight, usually, just to watch you. And you'll be sore a couple of days after, but Tylenol should fix that. Nothing more strong than Tylenol. But I will tell you, we need this kidney biopsy, okay? Don't be like, no, we don't need it, just try treating this out. Well, I cannot tell the stage of lupus. Okay, me and Dr. Jose, we're just shooting in the dark then. And so, can you go to the next slide, please? And one of the slides before I showed you, class 4 lupus, 44% progress on to end-stage renal disease in 15 years. So the kidney doctors, we really want to target these stages because these are active. At this point, it's chronic damage. So treatment is not going to affect much here. You can find it there, but at that point, there's chronic damage. I cannot do anything to reverse it. It is there, okay? But we want to target 3-4 as much as possible. So knowing the stages of lupus nephritis helps us, and the kidney biopsy is absolutely vital. So if your kidney doctor recommends it, strongly consider it, okay? Next slide, please. These are just pictures. This is not, a journal club, so don't worry, but this is what we look at. Literally, we sit in conference and look at your lupus pathology in the slide. So just for your purposes, this is a normal kidney, normal glomerulus, nice, healthy loops. This is a kidney that is diseased. You don't see the nice, healthy loops here that you see over there. In fact, you see more expansion, more cells that you don't like, and these can be immune complex deposits. And that's what medications are to fix. Can we go to the next slide, please? Again, the same thing. This is a nice, normal kidney, and God willing, this is all your kidneys. And we want to keep it this way. But we want to get rid of some of those changes that's going to affect your kidney function. And this is all lupus in the kidney, by the way. Next slide, please. Don't take a picture of this. Your nephrologist, your rheumatologist, they all have this. Okay? But the point I'm trying to show you is, it depends based on ethnicity. If you're class 3, class 4 lupus, what our first choice is, and it also depends on how much protein you have in the urine. What we're gonna determine what choice we use for immunosuppressants. Yes, Matt, did you have a question?
Oh, so I'm having flashbacks because I went through the kidney biopsy
Yes.
And I went through kidney failure with dialysis for maybe about a month. Love Medical College of Wisconsin, Froedtert, adore. That's why I'm still here.
God bless.
So I'm trying to figure out, so this is class 5, class
Yes.
B, I'm not good with numbers, Roman numerals. So that's the area where I was, if I'm correct, right? So if I was getting dialysis, that would be the area I was, or no?
No,
Not at all.
this has nothing to do with dialysis.
Oh, okay.
So these are just the stages of lupus in your kidney.
Okay,
It would mean you had that much damage that you temporarily needed dialysis.
Yes.
While your kidney recovered.
yes,
This classes by itself don't tell you the need for dialysis.
Okay.
You can be class 4 needing dialysis,
okay,
based on your kidney function, based on how much protein you have. Does that make sense?
it does, okay.
Praise God. Okay, so can we go to the next slide, please? Okay, this slide is probably the easiest slide which you can talk about. So treatment for lupus nephritis, almost always the base is steroids, and steroids is also for your lupus flares. And steroids have a wonderful side effect of causing you to lose weight, not lose weight, gain weight. Has everybody ever lost weight with steroids? Makes you more irritatable, make you more hungry, and it affects you as a patient, it affects your family members as well. So that's why I say I'm glad the Lupus Foundation is here, and support, you need social support, more than just you and your immediate family member. If you're part of a church, I highly recommend that. You need, because this is a chronic illness. If anything, my mom has burnt out doctors, meaning she cycled through doctors, meaning she could only put up with them for so long. So that is again not uncommon, because you don't live in a patient who has lupus's body. You are just a doctor trying to understand, and so don't feel badly if that happens. But if you were my mom or my brother, I would tell you, that would really help you, having people more than just the doctor you see 15 minutes every 3 months or whatever. Okay. So steroids, that wonderful side effect that causes, and normally when you have the kidney biopsy, you get stage 4 lupus, let's say. The nephrologist and the rheumatologist will be aggressive to try to suppress that flare. So normally it's 3 to 6 months of induction. And you use steroids, or they could use Cytoxan or MMF. Cytoxan can cause infertility. It's available IV. MMF is more well tolerated in that aspect. It doesn't cause infertility, but it causes a bunch of GI symptoms, and people don't like the size of the pill. But again, those 3 things they would use initially, one of those, combination of 2. There's also, people use calcineurin inhibitors. So voclosporin is one that is new recently that doesn't need as much blood draws, like Prograf, tacrolimus. I'm not mentioning these drugs for you to remember them, don't remember them, it's fine. But these are some induction agents depending on your ethnicity, depending on what class of lupus you have, that your rheumatologists and nephrologists may use. And that's induction. That can take 3 to 6 months of you being on this nice steroid dose and this immunosuppression. And now with COVID, you want to be careful about somebody who's sick coming to your home. If you're immunosuppressed, guess what? You're going to get sick very fast. So you have to be mindful of that. You're immunosuppressed when you're getting treatment. And then once they have everything under control, I'm going to go to that next slide. But then move to maintenance. Maintenance immunosuppression can go for like 2 to 3, 4, 5 years. Okay. So you are always asking the doc, can I get off of this? Can I get off of this? My mom always did. But and that is challenging because the doctor doesn't want your flare to aggravate up and wants to keep you where you are. You are cognizant of all the side effects that are happening. He or she is cognizant as well, but they're trying to keep your kidney going as long as they can. So that is the balance, and that balance, we want it in the patient's interest. So again, having a very strong alliance with your medical team can really help that, finesse that issue, okay? Azathioprine in patients who want to get pregnant or are pregnant is something that we use immunosuppression. ACE inhibitors and ARBs, I just threw this in here. These are actually blood pressure medications that are good for the heart, good for the kidney. They are not immunosuppressants. They decrease protein in the urine, okay? So if you have protein in the urine, you should be on one of those meds and they will decrease your protein in the urine. And we want to decrease protein in the urine because it's toxic to the kidney. Okay? And remember, protein in the urine has nothing to do with the protein you're eating. So you eat what you want still. But ACE inhibitors and ARBs, sometimes that is affected because your blood pressure is too soft. And lupus nephritis is often in many women, so many women have soft blood pressure, so you cannot tolerate the ACE. We'll see. Next slide, please. Thank you. I just showed you those meds. Those are the core backbone before. And just so you appreciate, this is from 2023, okay, with the Nature Review. All the red boxes are drugs they're working on, okay? So what I'm showing you right now could be very different in 10 years, okay? I talked about tacrolimus and voclosporin a little bit, some of them, but people are working on different areas to target for lupus nephritis, so keeping up on this, in 10 years you may see a little bit difference, okay? That's the only point of that. On to next, please. So response to treatment, a complete response would be the patient's protein in the urine is less than 0.5 grams per gram of creatinine, and the kidney function has stabilized within 6 to 12 months of starting therapy. That's fantastic, okay? That is the goal. But don't be disheartened if you have a partial response. Partial response is the protein in the urine is down like less than 3 grams, kidney function is stabilizing again, but that, nobody knows which patient goes which before we do it. And there's no response, and you can tell that because there's no change in protein function, kidney function is getting worse. That says no response, and when that happens, on to the next slide, please. When that happens, what the nephrologist and the rheumatologist look at is the patient able to take the medications? Sometimes patients can't afford the medication, sometimes they don't like the side effects, so they stop taking it. And then we may ensure adequate dosing of the medication. We may consider a repeat kidney biopsy, my friends, okay? Which many people, nobody's excited about, but a repeat kidney biopsy, and switch to the other first-line drug. So if you're on MMF, you go to Cytoxan. If you're on Cytoxan, you go to MMF. But these are all things your kidney doctor should be able to help you with. The point, if you're my patient, is you have to have an understanding of why your doctor is doing what he or she is doing. If you don't have an understanding, you should ask them about it, okay? And there should not be any guilt or, can't ask this question, it's too stupid. So that's his job or her job to answer your question. So I think if you don't understand this, long term it can lead to some burnout, okay, between in therapeutic relationship. Next slide, please. So concluding notes, lupus is very complex chronic condition driven by the immune system. And I'm a big believer in having a strong medical alliance between your doctors. Our doctors all talk to each other. If your doctor says he or she cannot talk to somebody, I'm sure that just give them the phone number. They'll take care of it. that is not, it should not be like that. Nobody talks to each other. Sometimes I hear this. And so, but I really, for this chronic condition, whether you're a patient or whether you're a caregiver, really focus in on relationships, and you have to have somebody you trust with, you have to build trust to listen to what the recommendations are, because those meds have difficult side effects, and we need to have an idea why we're doing what we're doing, okay? I just put my email address up there, just because if you want to ask me a question, this is not to ask me a specific question about your treatment plan, because I'm not going to break the trust of you and your doctor, okay? But this is if there is an anxiety-provoking question that you just want somebody else to say, oh, maybe you could consider this to your doctor. That's fine, that is the whole point about it. That's it. Any questions? Yes, ma'am.
Is there a certain amount of biopsies you can have?
So the answer technically will be no. But I will also tell you, they will not biopsy you 10 times. That is not, I think at that point you'll have scar tissue buildup. That is not a goal of a kidney doctor. And I will tell you, as a kidney doctor doing the biopsy, we are generally very conservative. At least I can speak of the medical college, we are very conservative. So meaning, we go in, I'm not going to do a biopsy just to show it's chronic. I'm going to do nothing about it. Normally we would go jump on your biopsy because we will change our treatment plan for you. Okay, so I can't speak for everything, but I would say, and there is a role for protocol biopsies, okay, because especially if you're in partial response with the treatment, to consider if things have changed, because lupus nephritis can also be there, but you can also have other things causing protein in the urine along with your lupus, like thrombotic microangiopathy. Big fat word, but ignore it. TMA, but it can also happen, and that will change your treatment plan as well. So can patients get 2 or 3 or 4 biopsies? It's possible, but it won't be within 1 year. It'll be over a period of time, generally speaking. Other questions, comments, criticism? Yes, ma'am.
Can you reverse or improve lupus or kidney function through your diet or exercise?
So, ma'am, I'm not saying this, so don't listen to one person and make up your mind. I'll say this. But if a bunch of people say the same thing, I will say sure. I will say the evidence, when they looked at the evidence for diet, that has not been shown to help lupus in the kidney. Can diet and exercise help your overall well-being? Absolutely. Some people with certain changes in their diet have less inflammation in their body, they feel mentally sharper. Because we're talking about lupus in the kidney, but if you're asking me, diet and exercise will absolutely help your well-being. And the more positive you are in your mind, the more higher the chance of your recovery from chronic illness. That has been shown. So if you have a more positive outlook, if your diet and if you're walking 3 miles every couple of days puts you in, gets you some good endorphins, and you're more. And I know lupus was exhausting for my mother, so she didn't like walking. So I get it. But if those exercise and diet help you get into a positive frame of mind, I'm all for it. So I'm not, if you ask me, can we do this gluten-free diet for lupus nephritis? There's no evidence for this. Okay. It's painfully hard as well, but I've had this question asked. Does that answer your question? I encourage watching your diet and exercising, absolutely. Other question? Yes, ma'am.
So with lupus, some people have a genetic component.
Yes.
But if there's also on the other side of a genetic component of chronic kidney failure or renal failure, does that mean that the person with lupus has a higher rate of possibly having nephritis if, one parent has renal failure and others have?
So God bless you. But your family predisposition, genetics, the ApoL1 gene specifically has been looked at, and I think Dr. Ozier has looked at this as well in her studies. But that is a predisposing factor. A predisposing factor doesn't mean a death sentence, but it is absolutely a predisposing factor, and that you can't change. You cannot change. None of us can change the genes we're born with, but you can be aggressive about watching your kidney function, watching the protein in the urine, things that you can control, your blood pressure, all those factors that you can control, you can do the best of. But I would say that is not by itself 100% death sentence. Do you agree?
Yeah. But there's no way to, really know, because even those who have the high risk genetic variants, not all of them progress to having kidney failure.
Praise God. And so whether you believe it or not, I'm not sure if I should say this, but this has nothing to do with Lupus Foundation or the NKF. I dare not endorse this message. I'm just saying this out of my personal experience, so I can say that. Having faith, definitely can help in this situation. I'm not saying you should not, but again, whatever gets you in a positive frame of mind. Studies have shown this. Yes, ma'am.
So apologies for coming in late, because y'all probably covered some of the stuff that I might ask right now.
No problem.
But, so faith immediately comes to my mind, because when I was going through kidney failure and I was going through dialysis, and I don't know how many people in the room have gotten kidney biopsies. Is there, okay, 1, 2, couple? You get through it. It's not the best thing on the list that you want to, have on your to-do, but
What's
you
the
get
worst
through
thing?
it. It's not.
Praise God.
Okay, cause I'm still here, right? And it saved my life. Faith first, and then the fact that there were good doctors and asking a bunch of questions, and they were on my side and trying to help me get better. But like you said, the good endorphins, smiling, just being positive. I think that's what my doctors told me really brought me through, that they could see, because they didn't expect that I would go off dialysis, especially as quickly as I did.
Praise God.
So, and I haven't had to have it anymore since then. So I'm very grateful. So faith is number one that I see.
So I'm just going to tell you, I didn't just say this as an opinion. I mean, there is, Stanford has looked at this. So they find the people that have a more positive outlook, whatever it is, whether it's faith or whatever you want to do, they tend to recover better. That is just what it is. So that's why I offer that up as it's been shown. I'm not endorsing any faith for you, but that's the difference. Yes, ma'am.
Since urine function is so important, why are doctors not taking urine samples? I can say in the last 5 years, I've been trying to give some feed, and they refuse to take it, just like it's not that important. Like you say, the protein doesn't really matter, you know, with the protein that you're eating. But it would be good to see if it's functioning at 80, 90, or what percent, or 70 or 40%. Since you say it goes with age also.
Yeah.
But why? I mean, they just won't put it on your blood workup.
So your blood workup, you know, I think you have a basic metabolic panel done every year, right? That has your creatinine in it. So every medicine doctor checks your kidney function at least
They
once a year.
do that, but they don't put the
The urine.
percentage of your kidney function.
So remember, I cheated. I told you the EGFR was a percentage. So it will never come as a percentage. So actually,
Well, I had a doctor that did it, and I'm just wondering why.
yeah, so
You know, why did
you
they
still have the
stop?
percentage.
They don't even want the urine anymore.
The urine is only to look at the protein in the urine. And maybe they said you have an excellent record of no protein in the urine. And they said just stop looking. Maybe that's what it is. But the urine will not give you the kidney function. But that percentage that you're looking for is actually in the blood work. It comes into EGFR. And if you look at that, it should say 60, 70.
Well, that and that creatine is on there, but like I said, my doctor used to say 80, 90% or whatever, and I like seeing that.
Yes. You should ask him or her to do it again.
Okay, the other question, some people with kidney failure say they stop passing urine.
Yes.
So what stage is that related to, or is it normal to put people on dialysis when their kidneys is still functioning a little bit?
So, great question. So you will stop making urine only when you're on dialysis. If you stop making urine and you're not on dialysis, you will be on dialysis pretty soon. Okay? So it is impossible. You cannot not pee for 2-3 days and be completely normal and feel normal. Okay? So the patients on dialysis generally, I'm saying generally because I have patients on dialysis peeing for the last 3-4 years. Okay? So it depends again. But generally they stop peeing after 3 months. And that is on dialysis. And remember, dialysis is less than 8% kidney function. Okay? So if you're on dialysis, you have less than 8% kidney function. Over time, because of dialysis, you will lose your ability to pee. But dialysis removes fluid, so you're still managing volume control. What was the second part of your question, ma'am?
I forgot.
Any other questions? Yes, ma'am.
Is there, and I can't recall the test exactly that is done, but it's a ratio, I think it's a protein ratio.
Yes.
What is there a magic number in that ratio where you should go from seeing your rheumatologist to seeing a nephrologist?
If you have lupus, I think your rheumatologist, if you have probably more than 0.5 grams per gram of creatinine, 0.5, he or she will want you to see the nephrologist because he's really concerned. I showed you a slide about manifestations of signs and symptoms of lupus nephritis. Protein in the urine is 100%. Your kidney function could be normal, but protein in the urine is a very sensitive marker. So if your rheumatologist notices that this is a little bit up, he will send you to the nephrologist to see, hey, do we want to consider, does the nephrologist also take a look at your urine in the microscope to see if there's any RBCs in there, and if there's some casts in there, because that may predispose them to consider there is inflammation going on in the kidney, and we want to get to it before it becomes chronic.
So if they're not sending me, should I be pushing for?
If they're not sending you with your rheumatologist and your kidney function is normal, there's no protein in the urine.
I do have protein.
Is it more than, well, you can ask the ratio, but if you can always ask them to go see a nephrologist, okay? And the nephrologist will say, you're fine. And that's better. That is, I'm not saying no, I'm not trying to drum up business for nephrology. Okay? you cannot see me because I'm the VA now, so I only see veterans. But I would say, ultimately, it's a question of trust.
I was put on infusions to bring it down.
Praise
So
God.
it's up, so the infusions have brought it down.
Excellent.
But I was never a nephrologist so far, so.
Yeah, it's not unreasonable to ask your rheumatologist to see, especially there's protein in the urine. I'm assuming your kidney function is slam dunk normal. Okay.
I'm not earlier, I was trying to figure out the ratio thing, so the percent, so.
Your creatinine, your serum creatinine that's in your blood work probably should be around 0.5 to 0.7. But again, you know, you should be okay. Yes, ma'am. Should be okay.
So I have a question about like natural medicines, so or like supplements.
Yes.
What are your thoughts about that? Or do you just feel like, okay, if you're gonna take your supplements, show your doctor who may just believe that they don't work, and I don't know, so what do you think about supplements?
You're asking me my opinion, okay? I'm just some.
Your
But I would say, you know, you can ask a bunch of other people as well. But my take on supplements is, if you take a supplement, know where you're buying it from. If you're buying it off some website and they have stuff in there that's gonna hurt your kidney, you're not gonna be happy. You know, some supplements, they're just giving water pills as a supplement to say it's a kidney drug, okay? And you're peeing more, you're thinking your kidney works, but it's actually a water pill. So I'm not against supplements, but I am against people taking supplements and not taking the actual medication because they believe the supplement. So these medications, they have, you know, patients have really, they've worked hard to figure out this regimen, not to cause harm, and they have actual data behind this. And you know, if the supplement if the supplement gives the patient a false sense of security, I don't want that, okay? So if it's gonna be otherwise, you know, I just wanna take this vitamin D tablet or this omega-3 fish oil, and I looked at it and it's in, all the ingredients are okay, it makes you happy, okay, fine, okay? But if it's, you know, you get it off some third world country and somebody told you this is gonna work. I had a patient just 2 months ago tell me this guy in India had fixed dialysis problems and they don't sell it in America, and he spent $300. And this is a real story. I'm not saying this, you know, to make fun of my patient, but he believed, and he sent this guy $300 to help his kidney. Well, I'm not holding any drug back for you. I mean, neither is NKF or anybody here. We don't want you on dialysis. We want you living on your own kidney. It's not, so I would say as long as the supplement doesn't give you a false sense of security, does not stop you from taking the medications with the rheumatologist and the kidney doctor that you trust, who are in your corner, I think you can work with them. Some supplements, you know, make some people happy, I'm okay with it. As long as it's, you know, some control mechanism to know the ingredients. Yes, ma'am.
When you were talking about having your team and dealing with your rheumatologists and nephrologists and that sort of thing, the realization, especially in the city, there's such a limited amount of rheumatologists. And the truth of the matter is, the actual time in which patients will get an appointment with a rheumatologist is long.
Yes.
So I think, you know, and it could be why one of the reason why she asked that particular question of maybe saying, hey, as my, you know, primary care physician, is there something that you can refer me to? Because if I'm waiting on my rheumatologist to do it, you know, you may have some delay in your stages of care. So my question to you is, do you have, or have you noticed that type of issue with some of your patients and delays of care because of when they've had their different stages and their referrals throughout the process?
So, if
I've had lupus for over 25 years, so I can be real honest with you.
God bless you. No, that's the whole point of this, right?
I mean, and I'm just saying that in sometimes as a patient and as an advocate, you almost know more than your rheumatologist at points, because of just, new, never experiencing it, it's not in the textbook that they read, and you're always that trick bag. So, just asking.
No, I'm with you. I mean, I said you were a professional patient or a professional caregiver when I started this talk. And I 100% believe it. I mean, my mom knows more than some of my residents and my fellows. The reason I hesitate to answer the question is, I think I'm in a system, the VA and the Medical College of Wisconsin, but there is many doctors, right? So it is not the same as here. And my patients work, they cannot make this like 10 o'clock appointment. But I would say, there is no harm in the doctor ordering the test, especially if you know the doctor. And you can go to the lab and get it done after work. And then the results come and you can talk to them. I don't know why we can't talk on the phone these days, but we can talk on the phone.
Because you don't get your doctor visit and your billing.
So my mom's-
And maybe I shouldn't say I work in healthcare. So administrative wise,
But
it's about the dollars too.
Yeah, so I think, but I would say, I understand completely what you said, okay? The doctor visit and many realities of it. But that's not an excuse. I would say you are well within your rights to get a better relationship.
Yes.
Frankly. Because honestly, I believe the medical college does a great job in that aspect. I'm not just saying this, but I really believe this because there is no incentive for me to make you come into my place, and they're not going to be paying me extra or whatever. But we can just do the best for your health in many aspects. The problem with the medical college, I think, is big. So when you come to see us, you are walking through like 10 different hallways, and so some patients don't like that. But I would say, your doctor should be able to, and I've sat in my patient's homes, and that is not medically paid or anything. But you should. I think you're entitled to ask them to talk to you. That is very simple. And yes, doctors are busy, blah, blah, but a rheumatologist and a nephrologist are not the same as the primary care doctor. The primary care doctor is filling out documents right and left, here and there. I don't blame them. It could take 2-3 days for them to get back to you. The nephrologist and rheumatologist, they're doing other things, good things, I'm sure. I'm a nephrologist. But we can, if my patient calls, we will call you back. Me or my nurse will call you back and give you an answer. But again, any relationship, there's some tug, right, initially. But then we love each other. but don't be afraid of that, is what I'm trying to tell you. Okay? Because lupus is very challenging. That's the problem. And any rheumatologists know this. They know this inside out. But that team, the whole team, I think, if you're too stretched running around doing reimbursable stuff and you have to take care of a patient, I don't know what to say about this. So I'm just going to say you're well within your rights to say, let me find somebody that works as well. I'm not encouraging this, just saying.
Oh, I've done it.
I was gonna say she an advocate. She know I go.
I'd be like, this is the last time I see you. Like,
Any other questions that I can answer? If somebody wants to ask me questions here in person, I'm happy to wait around. Yes, sir.
Does both kidneys get affected the same way when they're lupus involvement? And if so, how do you know which one to biopsy?
So we biopsy the one, so the kidney function test that you have is a composite of essentially both your kidneys. Unless one of your kidneys is like atrophic, meaning sometimes damage happens where one kidney is really small and the other kidney is big, then the kidney that is small is not really doing much. That does not happen in lupus nephritis. But it can, but in that situation you would know the small kidney is not really doing much. But if you have both kidneys that are the same size, you would biopsy the kidney that would cause the least amount of complications to you as the patient. So sometimes there's a cyst. You want to avoid poking that cyst. Okay? Whatever is easier for the ultrasound operator to make the shortest tracks, the needle is not going in longer than it has to. All those are the things that count. But it's a very interesting point that you bring up because there's more nuance there. Because sometimes if there is a certain type of entity in the kidney called a podocytopathy that can happen in lupus, you could have a little bit of a sampling error. And your nephrologist could say, maybe we need to biopsy this guy again. We're not happy about it, let me tell you. Neither is the pathologist. But it really, I could say, this could be an unsampled FSGS or it could be minimal change disease, and we debate this. She knows, Buki knows this, so we are arguing about this in our case conference. What should we do for this patient or not? So, but that's very rare. That's not common. Okay, common things being common, that's not. Does that answer your question?
Sort of. So both kidneys are the same size, not like one clear issue.
Yeah.
It would affect both the same, so it would show up no matter which one you biopsy.
Yeah, because lupus is a systemic illness causing inflammation and autoimmune deposits anywhere. It's not specific to one place, essentially.
Thank you.
Yes, ma'am. Okay. You've been a very kind audience. Thank you for the invitation. I'll stand here for a minute.
Thank you, Dr. Lathara.